I will actually talk about my experience with that. I'm shoulder surgeon now 42 years, and I saw thousands of patients with shoulder problem, with including cervical problem. So I will talk about our experience, especially in the diagnosis. I think this is very important because many patients are treated for shoulder problem and they have the problem in the spine, and opposite. Also, many patients are treated for spine problem and the real problem is in the shoulder, and sometimes you have both. Well, first I started my first clinic in my residency in 1981 in Neuwied, Germany, and then went to New York in the Presbyterian Medical Center, Columbia University, Charles Neer. And then I went back to Germany and started my own hospital in 89. It's shoulder and elbow hospital. We did about 90% shoulder surgery at that time, till 2 years ago when I got retired in Germany and came back to Egypt. Now I'm staying now in Egypt. So first I want to show you the diagnosis which we do, the standard. First we start actually with examining the cervical spine. This is very important. This is our shoulder examination which we do routinely for every patient. Then we examine the costal transversal joints. They are very important, as I will show you later. And then we start for the shoulder examination with the range of motion, then followed by the stability, anterior apprehension, posterior apprehension. This is anterior apprehension, this is posterior apprehension test, and then the inferior apprehension test, testing inferior instability. And then the thumb lower arm test for hyperlaxity. In this patient, he has a 0, so he's hyperlax. We examine the strength in the elevation and the external rotation. And then we see the tender points, AC joint especially, the biceps tendon, and the insertion of the supraspinatus. From my long experience, I can divide the main causes of shoulder pain are 24. 5 of them are causes in the shoulder causing radiating pain to the cervical or to the spine, and 2 of them are actually from the spine to the shoulder, which is from the neck and the costal transversal joints. The main cause of referred pain to the neck from the shoulder is the partial or complete tear. This is usually in patients above 40, and there is inflammation in the subacromial space, mainly due to impingement causing pain. This radiating pain in the neck is often treated for a long time for neck problems as a neck pathology, and then the patient comes to us after failed conservative treatment to the neck, and we see that he has a partial or complete tear. How we differentiate and how we will be sure of that, we do the test. We inject subacromial, in the subacromial space, xylocaine, and we see if the neck is getting better, even for 1 hour, and the pain in the neck is gone and the shoulder is better, so this is a clear indication that the problem is from the shoulder. Also, I want to mention that the treatment of rotator cuff repair, we have a transosseous repair and ankle repair. The ankle repair may cause also pain in some patients radiating to the neck, because it may be a little loose, or the formation of bone around the ankle take a couple of weeks, and this may cause pain also to the neck. Massive tears actually are also an entity which is discussed a lot, and most of the people or the colleagues say we do a total replacement, but also arthroscopic technique to repair massive rotator tear is possible. Like this patient, he is a very famous orthopedic surgeon in Egypt. And this is after reconstruction of his massive rotator tear. And then the patient, after 6 weeks from surgery, is having approximately completely normal shoulder. So, failed rotator cuff repair. This is also another problem. Patients who are treated with rotator cuff repair and it is failed, and they have pain also radiating to the neck, and they are treated for the neck problem for a long time, but the problem is the failed rotator cuff repair. How is that? The anchor may be loosened and it is in the subacromial space, causing irritation and pain, or there is a re-tear of the repair. This is also radiating. Also here as like a loose anchor also causes pain, which can radiate to the neck. Why I say that? Because rotator cuff tear is mainly in patients above 40. And patients above 40, they have degenerative problems in the neck. So when they go to the doctor, he say, oh, neck pain, make an x-ray, degenerative problem, okay, we start conservative treatment. So this age point is very important. This is not, of course, in young patients. Impingement, subacromial narrowing causing bursitis with canaralia. This is the second most common cause. And the test, also the injection test. The cause of impingements is also spur formation. The late stages of impingements can cause rotator cuff tear. This is also a cause of radiating pain. As Neergeer classified this entity into stage 1, 2, and 3, this is usually the impingement stage 2, which is radiating to the neck. This is the injection test to see to inject xylocaine in the subacromial space, and if the pain completely vanishes also from the neck, then this is the cause of the problem to be treated. The treatment is also arthroscopic subacromial decompression, which is now a very quick and easy operation. It takes about 15 minutes and the patient is relieved. Frozen shoulder. This is also another entity. The patient comes with pain, also can radiate to the neck, and the pain from the shoulder radiate either in cases of partial frozen shoulder, which is more common than total frozen shoulder, and in cases of total frozen shoulder, the pain actually is less. And we know the diagnosis of frozen shoulder is limitation of external rotation and elevation. Acromic clavicular joint osteoarthritis. Actually, this is also, we see that a lot in the clinic with pain in the neck. Also an untreated AC joint dislocation, which is later progressed to osteoarthritis, can also cause pain radiating to the neck, and the test of that is by injecting also inside the joint of xylocaine and to see if the pain in the neck also vanishes. The treatment of that, of course, is arthroscopic. We resect the lateral end of the clavicle to make more space and relieve the pain. And for, of course, dislocation, we do a stabilizing operation. Glenohumeral arthritis, either due to osteoarthritis or inflammation. Usually the patient complains of pain in the shoulder and the neck, and this pain is chronic, especially in cases of osteoarthritis. And also the same thing we do by testing intra-articular injection to be sure if it is only from the shoulder, if it is the shoulder, or if it is both the shoulder and the neck. The injection is also done for cases of subluxation osteoarthritis, and all the recurrent instability can also cause this type of pain, which can radiate to the neck. Now, this is actually a cause or a pathology which is mostly not noticed by many surgeons, orthopedic surgeons. The costotransversal joint. We have many patients coming with acute pain in the shoulder, severe pain, and they get treatment for weeks and months with no improvement to the shoulder. And it is actually a radiating pain from the costal transversal joints. Inflammation or subluxation of these joints affect the intercostal nerve, then they're radiating to the to the shoulder. If it is on the left side, many patients they have a heart attack. So it is really a very painful entity, and it is frustrating for many surgeons because it doesn't improve while treating the shoulder or possible orthopedic conservative means. We see, you all know, of course, this nerve distribution. We can do the test of that actually by injecting these facets or the costal transversal joint with local xylocaine under ultrasound, under sonographic examination location. I usually, with my experience, I can feel it, and we need just to inject a little bit on this AC joint, on this costal transversal joint, and you see that the patient immediately is relieved and the shoulder pain is completely gone. So that give us the hint to start treating this pathology. Another entity which is also not noticed by many, I say many because we see it a lot, of shoulder problem due to shortening of one leg and tipping of the pelvis, causing compensatory scoliosis affecting the costal transversal joints, leading to this shoulder pain. So, to know that, you have to examine the whole spine, the pelvis, how it is, and then correct that. Many patients, we just put them an insole with a slight correction of the height of the insole to correct the length of the spine will bring a very dramatic improvement. Now we go to the cervical spine. Cervical spine also can cause radiating pain to the shoulder. Of course, if we have disc prolapse on the nerve, make pressure on the nerve leading to radiating pain. This is actually usually when the patient comes, we treat the shoulder. We make these injection tests. Actually, it is very important, and we see there is no improvement at all. The patient has shoulder pain. We do an injection, no improvement, and he has symptoms of the spine. So it is a spine problem. Also, degenerative changes in the spine can also confuse us, but usually degenerative pain does not radiate to the shoulder. It's very rarely that it radiates to the shoulder. Now the question is how we go with treatment for that. The nerves are from up down, so you have first to start treating the cervical problem, and then after that the shoulder, because after treating the cervical problem, the shoulder may improve, not the opposite. While on examination and test, we do that the opposite. So here is also the injection. Now finally we see here the 5 causes of radiating pain from the shoulder to the neck, and the 2 causes from the neck to the shoulder. And we have to keep this in mind always while examining the patient. So, in summary or recommendation, examine the spine, the thoracic spine for costal transversal joint, the subacromial space, test the shoulder interarticular signs or tests, and the subscapular. Subscapular bursitis. This is also an entity which we can say that it's related to the shoulder, but it can confuse us between costal transversal joint symptoms and the symptoms of the bursitis. This is also easily tested by injecting the bursa, and you see if the cells on the back are gone or not. So if you have a spine and shoulder, we treat first the spine, and be sure of the diagnosis with injection tests. This is actually help us a lot, especially we start in the beginning, instead of just doing treatment and no response, and we just disturb the patient and confuse ourselves. And finally, thank you very much again for your invitation.